refresh பண்ணிடுவா இதுவே. Go live, huh? Go live, huh?
No sound is coming, no? Hello. Hello. Hello, Dr. Deepan Thakkar. We'll just start the presentation on venous drainage of the face. Just waiting for some more people to join. Hi, Dr. Rimpi. Okay, hopefully the audio is clear and the video is also clear. I'll just introduce myself. I'm Dr. Joseph Narkaugaran. I currently work as a fellow with Dr. Janaki Ram at Royal Pearl Hospital, Trichy. Hi Satya, how are you? So, I'm basically from Kerala. I've finished my MS in ENT from PG Hospital, Calcutta. Hello, Dr. Kumar Gavrav. So, it's already time, we are 10 minutes late to start the program. Hello, Dr. Subhadeep Das. So, we'll start. So, today's topic of discussion will be on the venous drainage of the face, that and the lymphatic drainage of the face. So, let us start with one of the small veins that drains the head region, particularly the posterior auricular region, which is the posterior auricular vein, which, as you can see here, it is marked in the yellow color. It begins up on the side of the neck in a plexus, which communicates with the tributary of the occipital vein as well as the temporal veins. So, this is the area of the superficial temporal vein, and here you can see the occipital vein. This is the area of the extra-auditory canal. So, the auricle will be here. So, it descends behind the auricle and joins the posterior division of the retromandibular vein. So, here you can see, what you see here is a retromandibular vein, and this is a posterior division of retromandibular vein. So, it joins with the post auricular vein to form the external jugular vein. This is the external jugular vein. So, what you see here is the maxillary vein, which is a short course vein which is formed by the confluence of the pterygoid plexus. The posterior auricular vein receives a emissary vein, which is the mastoid emissary vein, as you can see in the picture below. So, the mastoid emissary vein connects the sigmoid sinus with the posterior auricular vein. So the clinical significance of this is that any infection in the region of the posterior auricular region can be very fatal, because it can go in a retrograde manner to the posterior auricular vein through the mastoid emissary vein to affect the sigmoid sinus, causing sigmoid sinus thrombosis, and it can also extend into other deeper dural sinuses. So in case there is an emissary vein thrombosis, we all know there is a sign which is called as the Gray-Singer's sign, in which the skin over the mastoid tip as well as the occiput region, there will be edema over it. So that is the Gray-Singer's sign, which is due to the emissary vein thrombosis. Coming to the next region. So in this picture you can see this is the posterior auricular vein, and the next vein which we are going to discuss is the occipital vein. As you can see in this picture, the occipital vein is marked as yellow in color, and it drains a huge region of scalp in the occipital region. It begins in the posterior scalp. After beginning, it pierces the trapezius muscle and turns down into the sub-occipital triangle and becomes deep to it. The vein follows the occipital artery. It can directly end into the internal jugular vein, or which is actually not there in this picture. This is the region of internal jugular vein. It can directly go into the internal jugular vein in this area when it follows the artery, or it will drain into the external jugular vein. Coming to the next vein which we are going to discuss is the superficial temporal vein. The superficial temporal vein drains the temporal region of the skull as well as the scalp. So as you can see here, this is the superficial temporal vein. The superficial temporal vein in this region communicates with the contralateral vein on the other side. It receives blood also from the supratrochlear region, supratrochlear vein which will be somewhere here, and also from the supraorbital veins which will be in the area here. The other tributaries which it has is the posterior auricular vein. In this picture, the posterior auricular vein is removed. As you have seen before, posterior auricular vein is somewhere in this region and it joins the external jugular vein. It also receives blood from the middle temporal vein. As you can see in this picture, it is colored in green, as well as from the zygomatico-orbital vein. The other vein which drains into the superficial temporal vein is the transverse facial vein. As the superficial temporal vein enters the parotid gland, it goes inside it and it unites with the maxillary vein to form the retromandibular vein. So the retromandibular vein is formed by the union of the maxillary vein as well as the superficial temporal vein. This formation is within the parotid gland and it forms medial to the origin of the facial nerve trunk. So as you can see here, this is a styloid process and this is the stylomastoid foramen through which the facial trunk will come out. So this is an indicator for the facial nerve during parotid surgery. Next, going on to the pterygoid venous plexus. Pterygoid venous plexus is a plexus of veins which is seen in the infratemporal region. It is in close proximity to the posterior wall of the maxilla and extends up to the base of the skull. It is located mainly between the temporalis muscle, as you can see the fan shaped muscle, the temporalis muscle, and the lateral pterygoid muscles. Lateral pterygoid muscles here, and in the AP view you can see the lateral pterygoid muscle here and here. Some part of the pterygoid venous plexus is seen between the two pterygoids, that is the middle pterygoid as well as the lateral pterygoid. So as you can see, this is the two heads of the lateral pterygoids and this is the middle pterygoid. So the extent of the pterygoid venous plexus that is that anteriorly it reaches from the maxillary tuberosity in this region and extends superiorly up to the base of the skull in this region. Now, pterygoid venous plexus has a lot of tributaries. So, when we look at the tributaries from here, this one is the deep temporal vein. The deep temporal vein behind the zygomatic arch, it goes and drains into the pterygoid plexus. The other vein which goes in is the infraorbital vein. Infraorbital vein also drains into the pterygoid plexus. The third vein that drains into the pterygoid plexus is the sphenopalatine. Here, as you can see, this small short part which you can see, because this in here, this is the palatine bone. This is the palatine bone. The maxilla on this part is actually removed. Here you can see the palatine bone, the perpendicular plate, and here is the sphenopalatine foramen through which the sphenopalatine vein is coming into the pterygopalatine fissure, and then here is the infratemporal fossa where the pterygoid venous plexus is present. The other vein which drains into the pterygoid venous plexus is the inferior alveolar vein. As you can see here, the inferior alveolar vein which courses behind the lower part of the mandible and goes up behind the angle of mandible, goes up behind the angle of mandible and then joins into the pterygoid venous plexus. Likewise, the mesenteric vein, the buccal vein, the greater palatine vein, the inferior ophthalmic vein and the middle meningeal vein also drains into the pterygoid venous plexus. Coming to the surgical importance of pterygoid venous plexus. Pterygoid venous plexus connects with the cavernous sinus through the veins that pass through the sphenoid emissary foramen, the foramen ovale and the foramen lacerum. So, any reason of infection spreading to the pterygoid plexus can reach to the cavernous sinus, causing cavernous sinus thrombosis. As you can see in this picture, this lady's right side eye is affected with proptosis, chemosis and total ophthalmoplegia. So, the connection between the pterygoid plexus and the cavernous sinus is through the sphenoid emissary foramen, the foramen ovale as well as the foramen lacerum. The other case of significance is that when you give a alveolar nerve block, in case you give a alveolar nerve block, what happens is that the needle track causes a communication between the oral cavity to the pterygoid plexus. So, through this communication, through the track created by the needle, the infection spreads from the oral cavity to the pterygoid plexus. It can lead to hematoma, black eye and spread of infection to the external eye, as you can see in this picture. The pterygoid venous plexus is a source of venous bleeding in surgeries that involve the infratemporal fossa, the pterygopalatine fossa as well as in maxillectomies. So, during maxillectomy, during the fifth cut, you should be careful so as to not to injure the pterygoid plexus. Coming on to the next vein. The next vein which we are going to discuss is the facial vein. It is one of the main vein that drains the anterior part of the face. It is the superficial vein. It courses along the facial artery. The feature of this vein is that it doesn't have any valves. So, there is chance of backflow of blood through this vein. It originates in the medial canthus region. In this region you have the supratrochlear vein and the supraorbital vein which joins to form the angular vein. The angular vein forms in the medial canthus and it continues down as the facial vein. So, it commences at the root of the nose, lies behind the facial artery, but is less tortuous when you compare it with the facial artery. What are the tributaries of facial vein? The superior ophthalmic vein, the inferior papillary vein, the blue colored one here, the veins of the ala and the nose. The facial vein communicates with the pterygoid plexus through the deep facial vein here. The superior and the inferior labial veins, which is marked, superior is colored red, inferior is colored yellow, as well as the buccinators, the veins from the buccinator muscles, as well as the parotid and the mesenteric veins, the ones which are painted in green. So here you can see another image of the facial vein. In this image, the mandible is being removed to expose the floor of the mouth region as well as the hyoid. So below the mandible, there are four other veins that drain to the facial vein, which are the submental vein in this region, the tonsillar vein, which is not shown in this picture, the external palatine vein, which is colored yellow, and the submandibular vein. This is another view from the opposite side to show you the external palatine vein. Very clearly you can see it here, as well as the complete course of the submandibular vein. Now coming to the region of the orbit. Here you can see the supratrochlear and the supraorbital veins. This one here is the supratrochlear vein and this is the supraorbital vein. So the frontal tributaries of the superficial temporal vein. Superficial temporal vein will be somewhere here. So the tributaries from the frontal tributaries of the superficial temporal vein flow into the supraorbital vein as well as the supratrochlear vein. So a branch of the supraorbital vein passes through the supraorbital notch, which is somewhere here, to join the superior ophthalmic vein. So we will come to the superior ophthalmic vein shortly. So in this notch region, it also receives blood from the frontal sinus as well as the frontal diplobe. Both the supraorbital vein and the supratrochlear vein joins to form the angular vein in the medial canthus region, which eventually descends down. As you come down, forms as the facial vein in this region. So here is an image which shows the superior and the inferior ophthalmic veins. To identify them clearly, even though they are veins, I have colored them in red color. The one above is the superior ophthalmic vein, as well as the one below is the inferior ophthalmic vein. Here you can see the central lateral vein also taking a branch out of the superior ophthalmic vein. The point to be noted is that the pterygoid venous plexus communicates through a communicating branch to the superior as well as inferior as well as the superior ophthalmic vein, which in turn these two, superior and the inferior ophthalmic vein, communicates with the cavernous sinus. So we will come to the significance of that. Now if you look at this picture, which is an anterior oblique view, you can see the superior ophthalmic vein here, which goes behind the eyeball to join the cavernous sinus here, as well as the inferior ophthalmic vein, which also starts its course on the medial wall of the orbit and goes behind the orbit to join the cavernous sinus. Here also you can have a better picture of the pterygoid plexus, which has a communication through a communicating branch with the ophthalmic veins. In this picture, you can also make out the relationship of the cavernous sinus with the sphenoid bone. The dark brown color here is the sphenoid bone, but it's lesser and the greater wings are cut off. And this, the yellow one, is the optic nerve. So coming to one of the significance about this region is the carotid cavernous fistula. So as you saw earlier, the internal carotid artery is in close relationship with the cavernous sinus. It passes through the cavernous sinus. Cavernous sinus also functions to cool down the blood in the internal carotid artery as it goes up. So in this region is the internal carotid arteries. So there can be communication between the carotid artery and the cavernous sinus. So the communication can be a direct connection between the cavernous segment of the internal carotid artery and with the sinus, or it can be communication between the sinus and one of the branches of the internal carotid artery, or it can also be to the external carotid artery, or it can be to both. So this fistula formation can be due to any trauma which results in excessive blood, high pressure blood flowing into the venous plexus, the cavernous sinus. So when there is a lot of high pressure blood is coming into the cavernous sinus, that pressure is transmitted along the superior and the inferior ophthalmic vein into the eyeball, causing severe chemosis and congestion of the scleral vessels, which eventually results in decreased vision, conjunctival chemosis, external ophthalmoplegia because of the involvement of the 3rd, 4th and 6th cranial nerve, which are also related to the cavernous sinus here. So that will lead to external ophthalmoplegia. Pulsatile proptosis. So any case you see a proptosis and it's pulsatile, so there should be a high index of suspicion towards carotid cavernous fistula. It can also lead to orbital pain and audible brew. This is due to the direct communication of the arterial channels with the cavernous sinus. This is an MR angiogram of the brain showing the cavernous sinus involved in the fistula. So coming to the dangerous area of face, why is this triangular region of the face called the dangerous area of the face? So again, going back to the same thing, the dangerous area of the face, that is the vein supplying the dangerous area, the triangular area of the nose and the upper part of the lips. The veins which supply this region are valvulous and they communicate with the cavernous sinus. So it is dangerous because any infection in this region can be spread in a retrograde manner through the communicating veins, deep veins into the cavernous sinus. This is especially because the veins in this region are devoid of valves, especially the facial veins. So the facial vein connects to the cavernous sinus by two routes. As you can see here, this is the facial vein. The facial vein via the superior ophthalmic vein, as I said before, or the supraorbital vein, it communicates with the cavernous sinus above, or like we saw before, the facial vein communicates to the pterygoid venous plexus through the deep facial vein. So this is the pterygoid venous plexus. The facial vein will be here somewhere. So it will be communicating with the pterygoid plexus in this region through a deep facial vein. So this infection will spread along the pterygoid venous plexus through the emissary vein into the cavernous sinus. So any infective thrombosis of the facial vein may extend intracranially into the cavernous sinus and may spread further, causing neurological abnormalities. So cavernous sinus thrombosis can be septic, which is the most common cause. It can also be aseptic. So in this case, you can see the dangerous area of face is involved. The upper lip is spared, but the nose is involved. So through the above mentioned pathways, it can spread into the cavernous sinus, which eventually causes the infection spreading to the superior and inferior ophthalmic veins, causing cavernous sinus thrombosis and involvement of the eye. The symptoms, which include fever, proptosis, and cranial palsies, here now 3, 4, and 6 in 80 to 100% of cases. It can lead to decreased visual acuity and diplopia due to the involvement of the cranial nerves in 50 to 80% of cases. It can lead to severe complications such as hemiparesis, seizures, coma, and even death in less than 20% of the cases. So this is the septic cause of cavernous sinus thrombosis. Aseptic form of cavernous sinus thrombosis is due to trauma or any thromboembolic events such as increased factor 8, reduced factor 5, and protein C and S. It can also be due to dehydration and severe anemia. So the gold standard investigation of choice for cavernous sinus thrombosis is magnetic resonance angiography. As you can see here, the cavernous sinus is involved. The differential diagnosis for this condition is orbital cellulitis, orbital apex syndrome, and carotid cavernous fistula, as we saw before. Treatment for cavernous sinus thrombosis include anticoagulation using enoxaparin subcutaneously for 10 days, and which is followed by oral anticoagulation, that is warfarin 5 mg per day. Coming back to the veins. Now the maxillary vein. Maxillary vein is a short trunk which accompanies the maxillary artery. It is basically the confluence of the pterygoid plexus, forms a short stub of vein called the maxillary vein. It passes behind the sphenomandibular ligament and the neck of the mandible to enter the parotid gland. So behind the neck of the mandible, it enters the parotid gland and joins with the superficial temporal vein to form the retromandibular vein. Coming to the next vein. So we have done the postauricular vein, the superficial temporal vein, the pterygoid venous plexus. We have done the facial vein. We have done the maxillary vein. Now we are going on to the purple colored retromandibular vein. It is called retromandibular vein. As you can evidently see, it runs behind the ramus of the mandible. Here the mandible is cut to expose the vein very nicely, and it is colored in purple color. The retromandibular vein has a posterior division and an anterior division. The posterior division joins with the postauricular vein to form the external jugular vein. This green colored structure is the external jugular vein. And here, as we saw before, this is the occipital vein which is coming from posterior aspect to join the external jugular vein. The anterior branch goes forward and joins with the facial vein in this region. So what are the surgical importance of the retromandibular vein? As I told you earlier, the retromandibular vein formation occurs at a level higher than the passage of the main trunk and branches of the facial nerve, where they are lateral, they pass lateral to the vein. So here you can see the formation of the retromandibular vein from superficial temporal vein and the maxillary vein joining to form the retromandibular vein. So this is within the substance of the parotid gland, and it is, here you can see the trunk of the facial nerve is lateral to the formation of the retromandibular vein. In certain cases of anatomical variations, the retromandibular vein can pass lateral to the facial nerve or its branches. That is, the trunk and the branches will be medial and the vein will be lateral. So, in such anatomical variation, there can be risk of bleeding because we will be searching for the trunk of the facial nerve in this region during parotid surgery, and it can lead to the injury of the vein. And due to the anomalous location of the trunk and the branches of the facial nerve, there is high chance of nerve injury as well. But in normal variations, the facial nerve and branches can be localized by using the superficial temporal vein and the retromandibular vein as a guide. In the picture to the right, there is another variation of the retromandibular vein where it forms two loops to enclose the superior and the inferior division of the facial nerve. So, we have to be careful about the variations in this region during surgery of the parotid gland. Coming to the next vein, the lingual vein. The lingual vein drains the tongue, as the name suggests, as well as the sublingual region. So, the vein which is colored in dark pink color here is the lingual vein. The lingual vein has four main tributaries. One which goes here is the dorsal lingual vein, and the one in red color is the deep lingual vein. You can see a small sublingual vein here which drains into the lingual vein proper, as well as the suprahyoid vein which also drains into the lingual vein. So, that is the dorsal lingual, deep lingual, sublingual and the suprahyoid vein. One clinical feature you see is called the lingual varicosity. This is due to excess blood which is accumulating in the lingual veins. It is otherwise known as caviar lesions, where you can see abnormally tortuous vein due to prolonged intraluminal pressure and small purplish or black round swelling under the tongue. This happens with the aging. Usually the varicosities are seen in the calf, but here is another example of varicosity which is called as the lingual varicosity. Coming into the jugular veins. Now we have the anterior jugular vein, the external jugular vein, the internal jugular vein. The anterior jugular vein here is colored in yellow. The anterior jugular vein, so this is the hyoid. This is the omohyoid muscle, and this is the sternohyoid muscle. As you can see, the anterior jugular vein starts near the hyoid bone by the confluence of superficial submandibular veins in this region, which is not clearly shown. So, it starts near the hyoid bone and descends in the midline. These are the strap muscle. So, this is in the midline. So, it descends straight in the midline. We often encounter this vein during the initial steps of thyroidectomies. So, it descends in the midline and anterior border of the sternocleidomastoid in the lower part of the neck. It joins the external jugular vein here. This is the external jugular vein. It joins the external jugular vein or can directly drain to the subclavian vein. This is the subclavian vein and this is the internal jugular vein. Coming to the external jugular vein. The external jugular vein here in this picture, as you can see very clearly, it is colored in green. As we said before, the occipital vein is seen to be draining into the external jugular vein. So, the external jugular vein is covered with platysma and superficial fascia and separated from the sternocleidomastoid. This is the sternocleidomastoid, this is the cut end of the sternocleidomastoid, this is the trapezius muscle, and you can see the omohyoid here, and the sternohyoid here. So it crosses the sternocleidomastoid obliquely, slightly in an oblique fashion, and it can be seen very prominently when you do a Valsalva maneuver. The external jugular vein drains large area of the scalp. With the whole veins over here, everything is coming and draining into the external jugular vein. The external jugular vein, as I told earlier, it is formed by the union of the retromandibular vein here, posterior division of the retromandibular vein, as well as the posterior auricular vein in this region. So this region you can see the formation of the external jugular vein. So here again the mandible is cut, the ramus of the mandible is cut. This is forming behind the angle of the mandible, just below the parotid gland. So parotid gland also you can see in this region like this. The external jugular vein, as it goes down, it drains into the subclavian vein. So the tributaries are one on the occipital vein, the suprascapular vein, which is colored in red here. You can also see the suprascapular veins here. The dorsal scapular vein, which is colored in yellow, you can see it here as well as here. This is the dorsal scapular vein. The anterior jugular vein, which as we discussed earlier, is coming through the midline, and at the lower edge it is turning laterally to drain in the external jugular vein. The transverse cervical vein, which is not shown in this picture, and a branch from the internal jugular in the parotid region. So these are the tributaries of the external jugular vein. Coming to the internal jugular vein. Internal jugular vein, as you can see here, from the jugular foramen, it extends from the base of the skull all the way, it comes down through the neck to reach the thoracic inlet. So it collects the brain mainly from the blood from the brain. So it mainly collects the blood from inside the brain, and there are also few other veins in the neck region that drains into the internal jugular vein. We will come to it. Immediately below the jugular foramen, it is widened to form a superior bulb, which is contained in the jugular fossa. So this is the region of the superior bulb. It is located posterior to the internal carotid artery. So internal carotid artery will be somewhere here. It is going through the jugular foramen. Internal carotid artery will go like this, and at its lower end, at the junction with the subclavian vein, it again widens to form an inferior bulb. So this is the region of the inferior bulb, the inferior region where it joins the subclavian vein, whereas superiorly in the region of the jugular fossa, jugular foramen, the superior bulb. Posterior to the sternal end of the clavicle, the internal jugular vein combines with the subclavian vein to form the blue colored brachiocephalic vein. So this is the region of drainage of the internal jugular vein into the brachiocephalic vein, where it joins with the subclavian vein. So I said earlier, it mainly drains the blood from the brain, but there are certain peripheral veins as well which drains into the internal jugular vein, and it's of high importance during surgery, such as the pharyngeal vein, the common facial vein. This is the facial vein, as you can see, is going above. This is the common facial vein. The common facial vein drains into the interjugular vein in this region, as well as the superior thyroid vein. The one colored in pale white color, pearlish color, is the superior thyroid veins, and the middle thyroid vein. So during thyroid surgeries, during traction and dissection in the gutter between the carotid sheath and the lateral aspect of the lateral lobe of thyroid, we have to be very careful during traction and during dissection in this plane. We have to identify the middle thyroid vein. It may not be there in all cases. So, even while doing finger dissection in this plane, which is not very much advisable because of the presence of this vein. So, we should be careful not to injure the middle thyroid vein, as the middle thyroid vein, if it is injured, not only the vein gets torn, the tear can also extend into the internal jugular vein, causing massive bleeding. So, always while dissecting in this plane, you have to use gentle traction and fine dissection to find out the vein. Once the vein is identified, it has to be doubly ligated. So, this should be very important in dissection of thyroid in this region. Now, the other important clinical importance of the internal jugular vein is with the jugular venous pressure. The jugular venous pressure is an indirect measurement of the central venous pressure or the right atrial pressure. So, the patient is asked to lie down at an angle of 45 degree. So, the head, the neck and the head is elevated by an angle of 45 degree to see the pressure wave pattern in the internal jugular vein, as well as this is an indirect way of measuring the central venous pressure. So, what you do is, at this sternal angle, we have to place a JVP ruler, which is basically a scale, and we have to observe for the pulsation in the internal jugular vein, and you have to mark the highest point of pulsation, and you have to correspond that level with the scale and measure that length. So, that length is to be put here in the place of JVP in the calculation of CVP. So, this length where the highest point of pulsation is seen, that length is measured and that is put in this place of JVP, and you have to add 5 centimeters to it. This 5 centimeter is the distance between the sternal angle to the right atrium. So, this distance is 5 centimeter. This plus this will give you the CVP. So, if this distance above the sternal angle is more than 3 centimeter, then the jugular venous pressure, or in turn the central venous pressure, is considered to be elevated. So, this is an indirect way to measure the central venous pressure, which may be elevated in conditions causing increased volume of blood in the right atrium, like atrial flutter or right heart failure and other such conditions. So, this is one medical important feature of the internal jugular vein. The other applied aspects of internal jugular vein is, one is the Tobbe-Ayer test or the Quickenstead's test. This test is used in case of sigmoid sinus thrombosis. So, usually what happens is, in normal cases, both the internal jugular vein drains blood from the brain. So, the pressure is maintained within the brain, the intracranial pressure is maintained. So, in a normal individual, if you occlude one of the internal jugular vein, so that will decrease the drainage of blood from that side, and it can cause some increase in the intracranial pressure. Whereas in case of sigmoid sinus thrombosis, as you know, the internal jugular vein and sigmoid sinus is in continuation. If there is thrombosis of the sigmoid sinus, then blocking the internal jugular vein at a lower level will not cause any increase in intracranial pressure, which is measured through a lumbar puncture through which a manometer is connected. So, in case there is sigmoid sinus thrombosis, occlusion of the internal jugular vein is not going to change anything, because it is already blocked above. So, if you are blocking it below, will not change any increase in pressure. It may be normal, it will not increase. So in that case, Tobe air test is considered to be positive, which may indicate a sigmoidous thrombosis. Another relevant factor is that during neck dissection, the deep cervical lymph nodes, which are closely in relation with the internal jugular vein, when you dissect the deep cervical lymph nodes, I have to be very careful not to injure the internal jugular vein. The next factor is that in radical neck dissections, which is done for bilateral lymph node disease, metastasis of the neck. So in such cases, when we remove both the internal and the external jugular veins, in both sides, there will be decreased drainage of blood from the brain, because all of that brain now has to come down through the vertebral column with the vertebral veins, which is not sufficient enough. So if you sacrifice the internal and the external jugular veins on both sides, then that can lead to intracranial hypertension increased in ICP, which will subsequently lead to neurological problems and even death. Another issue with the internal jugular vein is the formation of a thrombus, which can later on cause infection in the thrombus, causing septic thrombophlebitis. A piece of the infected thrombus can dislodge and go to other structures, causing problems elsewhere. So the thrombosis and the septic thrombus is caused due to infections in the head and neck region, like chronic otitis media. It can be due to surgery, due to a CVP line placement, due to local malignancy. It can be due to polycythemia, hyperhomocystinemia, neck massage, and is also seen in intravenous drug abuse cases. Lemierre syndrome is a syndrome which causes the thrombosis of the internal jugular vein as a result of oropharyngeal infection. So when oropharyngeal infection extends into the internal jugular vein, it is called as a Lemierre syndrome. So one another medical aspect or a small procedure which is done in relation with the internal jugular vein is the placement of a central venous catheter. So a central venous catheter is placed into one of the large veins. It can be in the neck when it is placed in the internal jugular vein. It can be in the chest where it is placed in the subclavian vein, or it can be placed in the axillary vein, or in the groin, the femoral vein. So the need for a central venous catheter is for monitoring of the central venous pressure, to quantify the fluid balance for in cases of patients needing long-term antibiotics, parenteral nutrition, pain medications, chemotherapy. In all such cases, we prefer to use a central venous catheter which is placed in the neck into the internal jugular vein. So the technique which is used is called a cell lesion technique, where you puncture the internal jugular vein, then you pass a guide wire into it, then you use dilators, and then finally you pass the catheter over the guide wire to place it into the vein. One another common issue we have in the emergency department, as all postgraduates know, is a cutthroat injury. Why is a cutthroat injury so dreaded? It's because the internal jugular vein again is not very protected, it's very superficial. There is no bone or cartilage to protect it, so it is very susceptible to damage. And this venous column contains huge amount of blood, and any injury to the vein can cause massive bleeding, which can lead to hypovolemic shock and even death if it is not corrected properly. So as soon as there is a neck injury like this, firm pressure should be applied over the wound to avoid bleeding, as well as air getting into the internal jugular vein, because air getting into the internal jugular vein can go into the lungs and the heart and cause other obstruction problems, which also can lead to air embolism and death of the patient. Another aspect of veins, the importance of veins, is in the reconstruction in the plastic surgery department, where you use free flap for transplantation to cover surgical defects in the face or the neck, where we use a free flap. So, the use of the arterialized venous flap technique, that is the flap, the skin flap contains many veins, and it is ideally the center of the flap should have the more concentration of the veins, and ideally there should be one end for the anastomosis with the artery and two ends for the venous outflow. So, it should be designed in such a way such that most of the venous network is in the center, like you see in this picture. The artery inflow should be anastomosed to one efferent vein, here this is the efferent vein, and two efferent vein to drain the arterial venous flap. So, both the arterial and the venous trees are actively involved in the exchange of the oxygen and carbon dioxide. So, this is another clinical important aspect regarding the veins and the flaps, which are free flaps, which are used to cover the defects in the head and neck region, like the free radial forearm flap, where you use it to reconstruct the defects in the oral region or in the face region and the neck region or anything. One congenital deformity which is seen with the internal jugular vein is jugular phlebistasia. As you can see, this child has got prominent veins in the neck, which increases during straining or crying. This is a congenital dilatation of the jugular vein. It will be soft compressible mass, but it should be differentiated with other swellings in this region, such as the laryngocele, cyst, or any tumors of the neck. Venous malformations of this region include, as you see in this picture, huge lesions which are soft compressible. There won't be any bruit or pulsation, which suggests that it is completely venous in origin. Such lesions can cause to tremendous bleeding in case there is an injury, and in case such patients need surgeries in such regions, we should be extra precautious to avoid massive bleeding. Can be treated with sclerotherapeutic agents. Another case which you can see is the telangiectasia of the small veins and vessels of the skin. Usually these are seen in the face region itself. It is otherwise known as the spider veins. Such small venules and small vessels can be treated with the use of a laser. Another dreaded problem in this region is the AV malformation. So, there is a communication between the arteries and the venous circulation, causing huge tumors. In this case, it can be pulsatile, it may not be compressible. So, that is the end for our discussion on the venous drainage of the head and neck. So, moving on to our next topic is on the lymphatic supply of the head and neck region. So, the lymphatic drainage of the head and neck region are arranged into two horizontal rings and two vertical rings on either side of the neck. The outer, more superficial ring consists of occipital, preauricular, submandibular and submental nodes. This consists of the outer ring, whereas the inner deeper ring is formed by clumps of mucosa. This is associated with the mucosa, that is the lymphoid tissue associated with the mucosa, which is called as malt, which is located primarily in the naso and oropharynx, which is otherwise known as the Waldes ring. So, in this image you can see the axial section showing the Waldes ring, which consists of the pharyngeal tonsil, the tubal tonsil, the palatine tonsil, as well as the lingual tonsil. So, this region is called as the Waldes ring. The lymphatic drainage of in this region to prevent the infection going from the aerodigestive tract. The vertical chain consists of superior and inferior groups of chain, which is along the carotid sheath, as you can see in this picture. All lymph vessels of the head and neck drain to the deep necks. As you can see, all of them are draining down ultimately to reach the deep chain of cervical lymph nodes. The lymph which is collected in the deep lymph nodes enter the systemic venous circulation via the right lymphatic duct or the thoracic duct. So, coming to the classification of the lymph nodes, the superficial lymph nodes of the head include the occipital lymph node, the mastoid group of lymph nodes, preauricular group of lymph nodes here. So, as you can see in this picture, the green lines are the region where this particular group of lymph nodes drain, such as in the occipital group of lymph nodes gets their lymphatic drainage from the superficial cervical, the occipital part of the scalp, and then from here it goes to the superficial cervical lymph node and the accessory lymph nodes in this region. Whereas the mastoid group of lymph nodes, it lies superficial to the insertion of the sternocleidomastoid in this region. So, this is the mastoid tip. The sternocleidomastoid joins here in this region. So, the mastoid group of lymph nodes lies above the insertion of the sternocleidomastoid. So, this group of lymph node gets their drainage. They drain the parietal region, that is the posterior part of the parietal region, the skin of the ear, and the external acoustic meatus. From the mastoid tip, from the mastoid lymph node, which are the superficial lymph nodes, they further drain down to the superior deep cervical lymph nodes and the accessory lymph nodes, same as the occipital lymph nodes. So, they drain the posterior part of the scalp and the ear. Coming to the preauricular group of lymph nodes. This is the preauricular and the parotid group of lymph nodes. Coming to the preauricular group of lymph nodes, they are 2 to 3 in number. They are situated anterior to the ear, above the parotid fascia. So, they drain the region supplied by the superficial temporal vein and artery, as we saw earlier. This is the region of superficial temporal vein. So, it drains along that vein. The anterior part of the parietal scalp, whereas the posterior part of the parietal scalp drains into the mastoid nodes. The anterior part drains into the preauricular lymph nodes. It also drains a little part of the anterior surface of the ear. So, again, so these three are the superficial lymph nodes which we are talking about, all of which drain downwards into the deeper group of lymph nodes. So, as these two, the preauricular lymph node also goes into the superior deep cervical lymph nodes. Now, coming to the other superficial group of lymph nodes, which are the parotid group of lymph nodes. It can be seen within the substance of the parotid, between the deep and the superficial lobe. It can be in the under the parotid fascia. It can be deep to the parotid gland. So, this region again, it drains the external acoustic meatus, the frontal part of the skin, frontal and temporal region of the scalp, as well as the zygomatic region and the cheek and the nose. From here, the parotid group of lymph nodes again drains the same way as the preauricular lymph nodes into the superficial upper deep cervical lymph nodes. Now, the facial lymph nodes, there are two groups, again superficial and deep. The superficial consists of the maxillary, buccal and mandibular, which comes in this region. This is the submandibular group of lymph nodes, the buccal will come here, and the maxillary. They drain the region which is supplied by the facial artery and the vein. So, the lymphatics run along the facial artery and vein and drains the skin and mucosa of the lower eyelid, nose and the cheek. This superficial facial lymph nodes drain into the submandibular lymph nodes here. Whereas the deep facial lymph nodes, which are distributed along the maxillary artery and the maxillary vein in this region inside, so as to drain the temporal and the infratemporal fossa, which is deep to this region, and as well as the posterior nasal pharynx, and from there the deep facial lymph nodes again drains into the superior deep cervical lymph nodes in this region. Coming to the cervical group of lymph nodes, there are superficial lymph nodes as we said earlier, and there are deep lymph nodes along the internal jugular vein. So, the superficial group of lymph nodes drain anterior jugular vein region between the superficial cervical fascia and the infrahyoid fascia. So, these lie along the anterior jugular vein. It drains the skin, muscle and viscera of the infrahyoid region of the neck, which is the hyoid bone is here. So, this is the anterior jugular vein. So, these are the superficial group of lymph nodes and drains the infrahyoid region of the neck. So, this is the hyoid, this is the infrahyoid region. So, these are the group of lymph nodes which is called the superficial cervical lymph nodes. From the superficial lymph node, they drain into the superior deep cervical lymph node, which is seen in this region. Superior deep cervical lymph nodes. Coming to the anterior cervical and superficial group of lymph nodes, this submental lymph nodes, which is seen here below the angle of the below the mandible. The submental lymph nodes, which are 2 to 3 in number. It is located in the submandibular triangle. It drains the chin, the lower lip, medial part of the lower lip, the lower incisor teeth, gingiva, tip of the tongue and the cheeks. So, the submental lymph nodes drain this region of the medial part of the lip, the chin, lower incisor teeth, gingiva and the tip of the tongue. So, only this region. From the submental lymph node, the lymphatic is drained deep into submandibular lymph nodes, which is seen here. So, these group drain this region. From here it will flow here, and from here it drains into the submandibular group of lymph node. Again to the jugulo-omohyoid group of lymph node. This is the omohyoid. This is jugulo-omohyoid. So, from here it goes to submandibular, from there to the jugulo-omohyoid group of lymph node. From here it goes to the superior deep cervical lymph nodes. So, it flows in this direction. The submandibular group of lymph node, which is usually 3 to 6 in number, is found in the submandibular triangle. This is the submandibular triangle here, and it lies adjacent to the submandibular gland, as you can see in this picture, the yellow colored submandibular gland. So, the submandibular lymph node gets its drainage from the facial nodes, as we said earlier, the lateral part of the chin, the lateral part of the upper and lower lips, from the submental nodes, from the lateral part of the cheek, the nose, anterior part of the nasal cavity, the gingiva, the palate and the lateral part of the two-thirds of the anterior two-thirds of the tongue. So, this whole region, the lateral parts, is draining into the submandibular lymph node along with the facial lymph nodes as well as the submental lymph nodes. This again from submandibular lymph node, it goes into the superior deep cervical lymph node as well as the jugulo-omohyoid lymph nodes. Coming to the superficial cervical lymph nodes. It lie along the external jugular vein superficial to the sternocleidomastoid. So here you can see this is the external jugular vein, this is the internal jugular vein, and this is the anterior jugular vein. So superficial cervical lymph nodes are the group of lymph nodes which is seen on the alongside the external jugular vein. So it receives its drainage from the lower part of the ear. This is the extraordinary canal, so lower part of the ear and the parotid region, and from the superficial cervical lymph node it falls into the deep cervical lymph nodes which is seen along the internal jugular vein. The superior deep cervical lymph node. Now coming to the deep cervical lymph node, which is found along the internal jugular vein. So the superior deep cervical lymph node, which are this group of lymph nodes surrounding the internal jugular vein, deep to the sternocleidomastoid. This is the sternocleidomastoid, its clavicular end and the sternal end. So deep to the sternocleidomastoid, and the jugular omohyoid will be like here. Deep to that, you see the superior group of deep cervical lymph nodes. So they drain from the occipital lymph node, they drain the occipital lymph node, the mastoid lymph node, the preauricular lymph node, the parotid group of lymph node, the submandibular, the superficial cervical, which is seen here. This is the superficial cervical group of lymph nodes, and the retropharyngeal lymph nodes. So now it's all coming into picture. As we said before, the superficial group of lymph nodes such as the occipital, the mastoid, the preauricular and the parotid all drain to the superior deep cervical lymph nodes along with the submandibular and the superficial cervical lymph nodes. From the superior deep cervical lymph node, the drainage goes again inferiorly into the inferior group of cervical lymph nodes. So all this region first flow into the superior deep cervical lymph nodes, and from superior deep cervical lymph nodes they drain to the inferior deep cervical lymph nodes. Coming to the jugulo-digastric group of lymph nodes. As you can see here, this is the jugulo-digastric group of lymph nodes. It is seen at the junction of the internal jugular vein and the posterior belly of digastric. It drains from the palatine and the lingual tonsil, the posterior part of the palate and the lateral portion of the anterior two-thirds of the tongue. From the jugulo-digastric lymph node, the lymph drains into the inferior deep cervical lymph node. So from jugulo-digastric lymph node, the lymph goes down here into the deep cervical, inferior deep cervical lymph nodes. Coming to the jugulo-omohyoid group of lymph nodes. Jugulo-omohyoid group of lymph nodes, as you can see here, lies above the junction of the internal jugular vein and the omohyoid muscle. Where the omohyoid muscle crosses the internal jugular vein, that is where you find the jugulo-omohyoid lymph node. They drain from the posterior part of the tongue, as you can see in this picture, from the submental and the submental as well as submandibular group of lymph nodes, and from the jugulo-omohyoid lymph node, the drainage goes finally into the inferior deep group of cervical lymph nodes, which is found in this region. Now, inferior deep cervical lymph node. The inferior deep cervical lymph node is seen along the internal jugular vein below the omohyoid muscle, deep to the sternocleidomastoid. And this is the internal jugular vein, this is the omohyoid muscle. It is found deep to the omohyoid muscle, deep to the sternocleidomastoid muscle in this region. So the transverse cervical lymph nodes the anterior cervical lymph node, the superior deep cervical lymph nodes all drain into the inferior deep cervical lymph node, as we said earlier. From the deep cervical lymph node, it goes into the jugular lymphatic trunk, which is seen here. So finally, all ends up in the jugular lymphatic trunk. Now another group of lymph node is called as the retropharyngeal lymph nodes. The retropharyngeal lymph nodes are 1 to 3 in number. They drain the retropharyngeal space. They are found in the retropharyngeal space. They drain the posterior nasal cavity, the paranasal sinuses, the hard and the soft palate, as well as the nasopharynx, oropharynx, and the eustachian tube. From the retropharyngeal space, the retropharyngeal lymph node drains into the deeper cervical lymph nodes, the superior deep cervical lymph node group. The other group of lymph nodes which we said earlier was the axillary group of lymph node and the transverse cervical group of lymph nodes. Now, based on the levels of the lymph node and the imaging based classification according to the American Academy of Otolaryngology and Head and Neck Surgery, classification is that the level 1 group of lymph node is divided into the level 1A and level 1B, which comprises of the submental as well as the submandibular group of lymph nodes. They lie above the level of the hyoid bone here and below the level of mylohyoid muscle and anterior to the back of the submandibular gland. So, submandibular gland is somewhere here. This is anterior to the submandibular gland. So, the level 1A group of lymph node is the submental group of lymph node, whereas the level 1B is called as the submandibular group of lymph nodes. Coming to level 2, level 2 is again classified as level 2A and level 2B. Level 2A is that group of lymph node which lies anterior, medial and lateral to the or posterior to the internal jugular vein. As you can see here, it lies anterior or medial or lateral to the internal jugular vein, and level 2B is the group of lymph node that lies posterior to the internal jugular vein. Level 2A and 2B separated by the internal jugular vein. Level 3 is otherwise called as the middle jugular nodes. So, it is all the level 2 is called as upper jugular, this is the middle jugular, and this is the lower jugular. So, level 3 is the lower jugular, the middle jugular group of lymph node extend from the bottom of the body of the hyoid bone to the level of the bottom of the cricoid arch. So, here you can see the cricoid arch corresponding to the lower level, and the upper level of level 3 is the lower border of the hyoid bone. So, this is the area which is called as the level 3 group of lymph nodes between the lower border of the cricoid cartilage and the lower border of the hyoid bone. Now, the lower group of jugular nodes are called as level 4 lymph nodes. They extend from below the cricoid cartilage to the level of the clavicle. So, between the level of the clavicle and the cricoid is level 4, between the cricoid and the hyoid is level 3. Coming to the posterior triangle of the neck. The lymph node which is seen in the posterior triangle of the neck, which is seen here, which is bounded anteriorly by the sternocleidomastoid and posteriorly by the trapezius and inferiorly by the clavicle, is again divided into level 5A and level 5B. Level 5A is the upper level 5 nodes, which extends from the base of the skull here and extends to the bottom till the level of the cricoid cartilage again. So, the cricoid is a landmark here for both anterior group as well as the posterior group, which defines the level 3, 4 as well as 5. So, the group of lymph nodes which is found in the posterior triangle extending from the base of the skull to the lower level of the cricoid cartilage is grouped as 5A, whereas that which lies between the clavicle and the lower border of cricoid cartilage is level 5B. Now, level 6 is otherwise known as upper visceral nodes, which you can see here. This is the upper visceral group of lymph nodes. It lies between the carotid arteries on both sides from the level of the bottom of the body of the hyoid bone to the level of the top of the manubrium. So, this is the level of the manubrium. Between this clavicle and this clavicle, here is the manubrium, as you can see here, between the manubrium and the hyoid bone. In the central region between the two carotids is level 6. Coming to level 7, which is known as the superior mediastinal group of lymph nodes. Now, they again lie between the two carotids. You can see the carotid going here like this and the carotid going here like this in the central region above the level of the manubrium. The sternal notch is level 6 and below the level of sternum is the superior mediastinal group of lymph nodes. Now, the supraclavicular group of lymph nodes, as the name suggests, it lies at or the caudal level of the clavicle, but is lateral to the carotid artery on this side and this side. The retropharyngeal lymph nodes are another group of lymph nodes which lies within 2 cm of the skull base, and they lie medial to the internal carotid arteries. Coming to the lymph drainage of the external nose. We have already discussed the external nose drainage into the facial group of lymph nodes as well as the parotid group of lymph nodes. So, the drainage of the external nose primarily to the submandibular group of lymph nodes, through the superficial facial group of lymph nodes, which is the buccal and the maxillary group of lymph nodes, and goes to the superficial parotid group of lymph nodes. So, the root of the nose, the drainage is into the parotid group of lymph nodes, whereas the rest of the external nose drains into the submandibular group of lymph nodes. Coming to the internal part, the nasal cavity. The lymph vessels from the anterior region of the nasal cavity, they drain along the external nasal drainage into the submandibular group of lymph nodes. So, the anterior part of the nasal cavity drains along the same superficial external drainage of the nose into the submandibular group of lymph nodes. Whereas the rest of the nasal cavity, including the sinuses, the nasopharynx, the pharyngeal end of the effusion tube, they all drain to the upper deep cervical lymph nodes, either directly or through the retropharyngeal. Either the sinuses and every other part goes to the retropharyngeal nodes first, and then from that into the upper deep cervical nodes, or it can go directly to the upper deep cervical lymph nodes. Whereas the posterior nasal floor, they drain to the parotid nodes. So, the posterior nasal floor as well as the root of the nose. The root of the nose and the posterior nasal floor, these two regions towards the posterior part of the nose, both of them drain to the parotid group of lymph nodes. Coming to the lymphatic drainage of the tongue. The lymphatic drainage of the tongue can be divided into three main regions: which you can see as very nicely colored picture, into the marginal zones, the central and the dorsal zones. The anterior region of the tongue drains into the marginal and the central vessels, whereas the posterior part of the tongue behind the circumvallate papillae, which is here, behind the circumvallate papillae, drains into the dorsal lymph vessels. The more central region drains bilaterally into the submental. As you can see, it's going to the submandibular lymph nodes on both sides. So, the area of the tongue posterior to the circumvallate papillae drains into the jugular-digastric nodes. The central portion and the posterior part of the tongue drains into the deep cervical nodes on both sides. The lateral part of the tongue drains into the submandibular lymph nodes, whereas the tip of the tongue drains into the submental nodes, which will eventually drain into the submandibular lymph nodes. Coming to the lymphatic drainage of the teeth. The lymph vessels from the teeth usually run directly into the ipsilateral submandibular lymph nodes, as we have seen earlier, whereas from the mandibular incisors drain to the submental lymph nodes. The lower incisors is close to the submental lymph nodes, so that is how they drain. Occasionally, the molars may directly pass into the jugular-digastric group of lymph nodes, as we have discussed earlier, the upper deep cervical group of lymph nodes. Coming to certain applied aspects. Lymphadenitis is a condition where the lymph node, due to some foreign antigen or infection, become swollen and painful to touch. Once it is swollen, once lymphadenitis is set in, it can be palpated. It will be painful, and the commonly accessible lymph nodes for palpation are cervical lymph nodes, axillary lymph nodes, and inguinal group of lymph nodes. Lymphadenopathy is all the diseases that can affect the lymph node. It can be called as lymphadenopathy, of which one of the cause is the metastatic cancer. Coming to the neck dissection, block dissection of the neck. Neck dissection is considered as a treatment for malignant diseases involving the head and neck region, where it involves certain regions of the lymph nodes are selectively removed, or a radical or a modified radical neck dissection is done depending upon the nature of the tumor, the area which is affected, and the risk of micrometastasis. So, the removal of the lymph node of the anterior and the posterior triangles of the neck and their associated lymph channels, together with the structures surrounding the lymphatic structures, is possible. So, the neck dissections can be classified as radical, modified radical, functional neck dissection, anterior neck dissection, posterior neck dissection, and supraomohyoid neck dissections. This, like we earlier explained, in radical neck dissection, none of the structures are preserved. So, in this case, when a radical neck dissection is done bilaterally, where you remove both the internal jugular vein as well as the external jugular vein on both sides, then it can lead to decreased venous drainage in the brain, causing a increased intracranial pressure. Other diseases that affect the neck nodes are tuberculosis, which is very common in India. They usually involve the upper deep cervical chain of lymph nodes. They can be very firmly adhered to the internal jugular vein. Then comes the glottic cancers. Supraglottic and subglottic tumors drain respectively into the upper deep cervical and lower deep cervical lymph nodes. So, the upper deep cervical lymph nodes, they drain the supraglottic larynx. So, in 40% of this supraglottic CA cases, there will already be a upper deep cervical lymph node metastasis in 40% of the cases. Whereas the glottis, the glottic region is very poor in lymphatic vessels. So, in more than 95% of the cases at presentation, the glottic CA will present without a lymph node metastasis because they tend to present more early due to early symptoms such as change in the voice or airway obstruction. The tumors of the subglottic region spread to the paratracheal group of lymph nodes. So, before they clinically present to you, paratracheal lymph nodes may already be involved. However, the presenting symptom may be a voice change or airway obstruction rather than a mass in the neck, because paratracheal lymph nodes are not very easy to palpate, even though they can be picked up in the CT scans. So, some small points regarding the physical examination of the lymph nodes. So, during examination of the lymph node, we have to make sure to know the extent of the lymphadenopathy. Is it a localized lymphadenopathy only in the neck, or is it generalized, found in other parts of the body? The size of the nodes, the texture of the nodes, the presence or absence of nodal tenderness, signs of inflammation over the node, skin lesion and splenomegaly. Coming to the size of the lymph node. The lymph nodes which are less than 1 centimeter in size are almost always secondary to any benign or reactive causes. In many cases, when we have a lymphadenopathy and we do a FNAC, we get the report as saying as a reactive lymphadenitis. So, it can be due to non-specific causes. Patients with nodes of 1 centimeter should be observed for any infectious mononucleosis or toxoplasmosis. Coming to the texture of the lymph node. While you do the physical examination of the lymph node, the texture of the lymph node, the feeling should be described as soft, firm, rubbery hard, discrete or matted. It can be tender or non-tender. Is it fixed or is it movable? The tenderness is found when the capsule is stretched during rapid enlargement. This is usually due to a inflammation in the lymph node. Rapid enlargement and pain also can be due to certain malignant diseases such as acute leukemia, when there is very fast increase in size of the lymph node and as well as there will be pain. Now, the lymph node chain palpation starts with the parotid and the preauricular region of the lymph node, and the technique which is used is a bimanual palpation, palpating with light finger pressure against underlying firm tissue or bone, or bimanually wherever it is appropriate. The examination continues down to the mandible, to the submandibular region, where the bilateral palpation proceeds further towards the submandibular group of lymph nodes. So, as you palpate, there should be a flow in palpation of the lymph nodes, starting with the parotid and preauricular region, in a bimanual fashion, going down towards a submandibular region along the mandible to the submandibular region, then towards the submandibular group of lymph nodes. The patient position should be, sitting upright with head slightly bent forward, and the cervical lymphatic chains are palpated. So, first we start with the parotid and the periocular group of lymph nodes, then we go along the mandible to the submandibular region, then you go to the submandibular group of lymph nodes. After checking the submandibular group of lymph nodes, we move towards the cervical group of lymph nodes, where the patient is asked to sit upright with head slightly bent forward, and you palpate the neck. Then talking a little bit of the lymph node biopsy, I think it's a little too late to go ahead with the laboratory investigations. So, I will skip to the radiological features. So, in normal ultrasound, the lymph node appears as a flat hypoechoic structure with some amount of fat in the hilar region. Whereas in malignant infiltration of the lymph nodes, what you can see is that the size is enlarged and the shape is usually round, and there will be increased vascularity within or around the lymph nodes. So, here you can see this is an image of a level 4 lymph node in a patient with squamous cell carcinoma. Here you can note that the hyperechogenicity compared to the peripheral cortex, which is hypoechoic, and the total size of the lymph node is also increased. So, this all points towards a malignant metastasis into this lymph node. So, you look at the hilum and the cortex. The hilum is hyperechoic compared to the cortex, which is hypoechoic, and the total size of the lymph node is also enlarged. So, for the management of a CA patient, you have to identify the involvement of the cervical lymph nodes. So, the treatment will depend upon the presence or absence of cervical lymph node involvement. It also has prognostic significance as well. So, the general criteria for imaging which is used to determine the cervical lymphadenopathy are nodal necrosis, heterogeneous appearance, eccentric cortical widening on USG, and the recent imaging advances which shows the functional nature of the lymph nodes are the glucose uptake by FDG PET scans, as well as use of tissue specific MRI contrast material. CT scan is the main modality of neck imaging still being used, a contrast enhanced CT. So, it is used, the axial planes are used in 3 or 5 millimeter cuts with the use of intravenous contrast. The CT criteria for assessing lymph node metastasis are based on the shape, the size, the presence of central necrosis, the appearance of cluster of lymph nodes in the expected lymphatic drainage pathway of the tumor. So, the criteria are based on the shape, size, presence or absence of central necrosis, and presence of cluster of lymph nodes along the drainage pathway of a particular tumor. The most effective size criteria is that a minimum axial diameter of more than 11 mm in jugular digastric region and more than 1 centimeter in any other lymph node regions is the criteria of size to consider a node as malignant or not. Nodal grouping in the drainage chain of a tumor is a further indicator of metastatic disease. What is nodal grouping? Nodal grouping is defined as 3 or more contiguous or confluent lymph nodes, each of which has a minimal axial diameter of 8 plus or minus 10 millimeter. So, nodal grouping is that there is a group of 3 or more contiguous or confluent lymph nodes with each of a size 8 plus or minus 10 millimeter in diameter. So, this is indicative of a metastatic spread. Whereas the most accurate CT predictor is the presence of a central necrosis in the lymph node, which is 100% specific to the malignant involvement of the lymph node. So, the central area is seen as a low attenuation surrounded by thick irregular rim of enhancement and is due to nodal replacement of medulla by the tumor. So, in CT the central area is of low attenuation, whereas in the ultrasound the central hilar region is hyperechoic and the surrounding cortex is hypoechoic. It is somewhat the opposite in CT scan, where the central area is low attenuation and the surrounding area is thick and irregular. So, there is a picture of axial CT scan with contrast showing a left sided tongue CA extending through the midline. So, this is the tumor and there is bilateral lymph node enlargement seen on both sides with the marked central necrosis. So, this is the feature of the lymph node metastasis, where there is central hypoattenuation with a surrounding thick irregular thickening on the outer edge of the lymph node. You can see another lymph node here and the same feature. So, nodal necrosis can be mimicked by lipid metaplasia, which is due to fat degeneration due to inflammation or radiotherapy. But the contrasting feature is that this fatty change occurs in the periphery, not in the center. Another which is strikingly similar appearance is we get a similar appearance in the abscess formation. So, this is another axial CT scan with IV contrast showing lipid metaplasia with an eccentrically placed in the left submandibular lymph node and is a 6 millimeter in diameter. So, this size is also not very huge, as you can see here. The necrosis which looks like necrosis, but it is not in the center, it is pushed towards the periphery. So, this is a case of lipid metaplasia where there is fatty degeneration. It is seen in the periphery, not exactly in the center, plus the size is less than 10 millimeter. Coming to the MRI imaging. So, for cervical lymph nodes we do a T1 and a T2 imaging, whereas STIR sequences allows combination of both T1 and T2 with fat suppression. So, the fat changes are not seen. The malignant nodes are clearly seen as a high signal. In the T1 images, the lymph nodes are of intermediate intensity, which is very similar to the muscle, while as T2 shows a hyperintense signal. So, what are the features of a malignant lymph node in MRI? Is that the malignant lymph node is of high signal. In T2 it is hyperintense, whereas in T1 it is intermediate, just like another soft tissue. So, here you can see T1 and T2 images. In T1 the center of the lymph node is iso-intense to the muscles. It is of the same intensity, whereas when you come to T2, the central necrotic area is hyper intense. So this shows that this particular lymph node is a malignant lymph node. The newer technologies are a PET scan. So it is where we use radio labeled glucose analogs. FDG glucose uptake is seen because the malignant tumor there is increased glycolysis, so hence there is increased uptake of the glucose. So PET scan provides a functional rather than a anatomical imaging, the functional status of the tissue, whereas in this case, since the malignant tumor has enhanced glycolysis, there is increased uptake. So that is the basis of a positron emission tomography. So here you can see this is the PET scan of the thoracic region. In the axial normal CT scan, there is mixed soft tissue here and some fluid, whereas in the same section when you do a PET CT scan, it shows increased uptake in this soft tissue region with increased uptake in the lymph nodes as well. So this indicates there is a recurrent tumor in the lungs with involvement of the lymph nodes. So we are about to conclude the talk on the lymphatic drainage as well. Just a couple of slides more. So the other advanced imaging techniques which are used are planar lymphoscintigraphy, a hybrid SPECT CT imaging, a dynamic contrast enhanced MR imaging, ultra small super paramagnetic iron oxide enhanced MRI, and a gadolinium enhanced MRI. So we have come to the end of the talk for today. Hope at least some of you might be benefited from the class. So anybody, if you have any doubts, you can ask now. We can clarify any doubts that you have. So thank you everybody for listening today. It was a long class. It was supposed to end at 10 o'clock. It's already 10:45. So I think we can call it a day. So thank you everybody. Have a good night's sleep. Good night.